Great. Thanks so much, Tim. We have just a couple minutes left with that. So I'm going to move right into a question that was posed by one of the public viewers of the panel. And I'm going to direct it first to Nuala and then see if anybody else wants to weigh in on that. The question is sepsis better defined by end organ dysfunction or by signaling dysfunction? And the follow-up part to that was, are we then targeting the right clinical interventions through targeting our interventions towards end organ support, or should we also specifically be targeting signaling dysfunction? So Nuala, I'm going to direct that to you first and then see if anybody else from the panel wants to weigh in.
Yeah, so what an excellent question. So I do think we probably have overly focused on the organ dysfunction to some extent. And in a way that's been helpful. I think our supportive care makes sense by an organ specific. Certainly if we take the lung as an example, being careful about the ventilator, it definitely makes sense to think of the patients with ARDS or at risk for ARDS getting specific ventilator therapy. But your point about missing the signaling, we would definitely like to get back to that treatable trait paradigm where maybe some patients have ARDS, manifest ARDS because it's a permeability problem and an anti-permeability therapy would help. And maybe others, it's more an inflammatory problem and a specific immune intervention might help. So I think both are important, but to really have specific therapy, the signaling will be, we definitely need to better understand.
Tim, what are your thoughts?
I would strongly agree. I think that especially now with COVID, we're seeing a lot of reinvention of the wheel in terms of people trying to focus on the signaling. And I think that's great in a lot of ways. But, you know, whether it's Roche's more recent failure with the IL-6 inhibition or some of the other sort of early reports we've seen of other single cytokine signaling interventions, I think that in the end, the sepsis is a signaling problem. It's not it manifests with end organ dysfunction, but it starts with immune dysregulation. And 10, 15, 20 years worth of drug trials shows that sort of single targeted signaling approaches, even though they hold a lot of promise in theory, tend to just fail in practice. And I think that one of the things that is gaining a lot of steam is the need for a diagnostic to show what subclass, what signaling process is dysregulated in this particular patient, so that we might be able to match a patient to their therapy. So maybe IL-6 is great for some patients with COVID. Maybe other patients need an anticoagulopathic drug, and we just have to figure out which is which, because there's not just sort of one signaling pathway that's aberrant across all patients with sepsis. And I think that the endotypes, the treatable traits, there's a lot of different language being used here, but that's going to be the key is sub-selecting which signaling pathway is wrong so that we can really target it.
Great. Thank you both for that. And with that, we're at time, and I'm going to conclude our session 2 here. I want to thank personally all the National Academy staff for their flexibility on the fly with this, and particularly all of our speakers and panelists. Thank you guys for a really provocative session.